We get 3 participants so far. Okay, so a couple of people here. So Mark and I are from the AAEM Physician Group. I'm the Chief Medical Officer. Mark's the CEO. And we're going to give a talk on, contract pitfalls, basically. We gave a similar talk at the AAEM Scientific Assembly, and we're just going to go back and forth. I'm been with the physician group since it started. And Mark, I guess you can introduce yourself as well.
Hey, I'm Mark Reiter. I'm a residency director at University of Tennessee, Murfreesboro, Nashville. And yeah, I've been on the AAEM board for about 15 years, and until recently when I took over on the AAEM Physician Group board, chairing that board, and now as its chief executive officer. I'm also a former president of the American Academy of Emergency Medicine.
All right, so we'll flip through some slides here, and then we'll have plenty of time for Q&A. Oh, host disabled participant screen sharing. I need to be able to share my screen. Unless I got to be able to share my screen.
All right, Bob, it looks like I'm probably gonna be able to do it on my end, okay?
Either way, you both should have access now.
Oh, we can both do it? All right. I have it queued up if you. Is that you or me?
All right, Bob.
Okay. All right, so I'm going to do the red slides and you're going to do the purple slides. So this is what we're going to talk about. We're just going to review some problematic contract issues, running this list down here. Obviously, due process, there was some earlier talk about that, termination, the old restrictive covenant, non-interference, malpractice, and indemnification, and then talk a little bit at the end about compensation, bonuses, and hours. All right, let's flip to you, Mark.
All right, so when you've got a employment contract with a group, official recommendation is, of course, get somebody with legal expertise and an attorney to do a review. If you do go ahead with that, the better thing is to not just give them a 30-page contract to review. That's going to cost you a lot more money. Better to have really looked at it yourself, identify if there are any issues, if there are things you don't understand, if there are things of concern, and then have them really just review particular sections and answer particular questions. Okay. That being said, I think a great idea is to have an experienced colleague take a look and see if there are issues with the contract. Often this might be the department chair or a program director, or somebody else who has a lot of experience looking at these contracts. Folks like Bob and myself have been looking at contracts for our residents for years and years and years. So we've reviewed hundreds and hundreds and hundreds of contracts, and we know a lot of the red flags and funny stuff that goes in them. So another thing is you got to kind of consider your source. How trustworthy is the group? There are certain types of groups that their reputation is that they're not going to ever change that contract. This University Medical Center, this is their contract. This is what they do. They're not going to change anything, and you get what you get. You might have a private group, independent democratic group that's got a really long history of really treating their people well. I might not be quite as concerned about things that are more gray area in the contract with them. On the other hand, if you got a group that has a reputation that people have had problems with them in the past and things like that, and that you don't really think that they're looking out for your best interest by any means, go over this stuff really carefully. Make sure you're having people look at it, spend some extra money if needed, have experts look at it there. And then when you're looking at a contract, you got two things that you're really trying to accomplish. One is, am I okay with everything here, or do I want to consider a different job because it's not a good contract, not a fair contract? And two, if it is my preferred job, are there things that I could potentially change on this contract to make it a better contract and a better potential employment situation? And a lot of that is really about leverage. If you're in a situation where they need you more than they need them, than you need them, they're gonna be a lot more inclined to make changes to your contract if they are, you know, an entity that's open to that. On the other hand, if, you know, they've got tons of applicants, you're not that different than the other applicants there, and you're kind of pushing things too hard that I want to make all these different changes and things like that, then you could potentially even jeopardize your job prospects with them. But certain things, and we'll talk more about restricted covenants and things like that, are more likely to be deal breakers when we're talking about emergency medicine contracts.
So due process and termination clauses are certainly something that is, you know, key to AAEM. You know, there's been a fair bit of talk about this, already taking him back. So it's fairly common when you look at your contract to see a laundry list. We're going to end this contract for cause. Some of them are, you know, very, very obvious. You know, you lose your license, you can't practice medicine. If for some reason you would run afoul of the Medicare, Medicaid, got excluded from payments for CMS. These are things that are rare, but obviously they wouldn't be able to bill for you. Being convicted of a felony, you know, so you need to see what the for cause reasons are, all right? Because if you get terminated for cause, it's, you know, that's a big deal. If you have to say that on your next application, I got terminated for cause because of this kind of issue. So really should look at it, make sure they're fairly straightforward and objective, that there aren't some, you know, things there that are vaguely worded. There are some times where the for cause thing, you know, you wind up for cause is because the hospital administration, you know, requested your removal. You know, that invokes the issues of due process. Certainly, you know, what we more commonly see is you can be terminated without cause, and they put a time period on that. So obviously, if they say we can immediately do this, you know, you could be out of a job tomorrow if somebody complained about you. You know, how short of a window? You know, what we're commonly seeing is 30 days, 60 days, 90 days. And then they say, well, hey, you know, you need to give us 90 days notice to terminate the contract. If, you know, we're just doing an equal thing here. And it's not really equal because you don't own the ED contract. But if you look at the without cause termination or against, you know, we think they should be for cause. You know, you need to see what the window is. And you can certainly negotiate. Well, what do you mean I can be terminated within a week? That's not enough time for me to adjust and to, you know, get my family in order or try to find another job. So I would, you know, be very careful about the length. When you do this without cause, there's usually a co-termination of medical staff privileges attached to that. They say, you know, when we terminate you, you have no rights under the medical staff to appeal this. Again, you know, technically violates, you know, the Joint Commission and the Department of Health in most states. Kind of gets into the third bullet there, you know, what resources exist. If you haven't read it, you can go to the AAEM website and look at a white paper on due process put together by Dr. Larry Weiss, a former president of AAEM. You know, basically, you know, he ties it to the Constitution that, you know, you're being deprived of your ability to make a living. You know, that's a sort of a constitutional protection. And then there's all other kinds of rules and regulations. The Joint Commission expects medical staff members to have access to due process. You know, you technically even get due process if you're not a medical staff member. If you apply to the medical staff, you have a right to contest rejection of that. And then most states, Department of Health regulations for hospitals also parallel what the Joint Commission rules are. Now, the trouble here is that, you know, the hospital says, well, it's not us, it's the contract group that's terminating you. And, you know, this is part of what we have this HEROES Act that we're trying to put through with Congressman Ruiz and whatnot, where it's going to say that if, you know, conditions of participation for Medicare will not allow emergency physicians to be denied due process through third-party mechanisms. Ergo, having a corporate group have this clause where they're able to termination. So that's due process. Now, why are we all? Well, this is a study. Mark was a co-author on the study. We were going to CMS. We were trying to get CMS to change the rules. It's a bureaucracy. And we gave them a lot of information. We said it affects the quality of care. We showed them all kinds of stuff. And they basically said to us, well, you got all these stories and anecdotes, but we don't know if we can move on this. Can you do a study? So we did a study. We surveyed practicing emergency physicians. This was an AAEM-based study, so most of the respondents, of course, are going to be board certified, 86%. And there you go, 3/4 could be removed by a hospital administrator from the schedule. I mean, that's crazy. 60% said they could be terminated without due process, and 1 out of 5 of us said they thought that they would threaten their job if they spoke up about the quality of care. And we had some other findings in the study that docs were pressured to admit patients who were going to be financially beneficial, discharge or transfer those who were not. And again, our efforts were trying to get this one section of the Code of Federal Regulations changed, the conditions for participating hospitals. There's an actual subsection on emergency services. So we've created language we're trying to get inserted into the CFR. Okay.
All right. One of the things you really got to look out for in a employment contract are restricted covenants. Restricted covenants, also known as geographic non-competes. Okay. And you can get burned a lot of different ways if this is in your contract. Okay. For one, you can be fired, or you can, be let go, just not renewed. You may choose to quit because it's not a good job opportunity. And you can love that job and they love you and you're the best doc at that hospital and everything's great, but the group ends up losing its contract. And if you have a restrictive covenant in place, then that restrictive covenant may read something along the lines of you cannot continue to work at that hospital if there's a change in control. You may not be able to work at other hospitals within X miles away, and that could be a big area. It could be 50 miles away. And that can be for a year or 2 years or sometimes even longer. So what does that mean? That means that you end up having to, sometimes for no fault of your own, just the contract switches, that you end up having to leave your job that you like a lot, that you might end up having to move your family and sell your house, and the spouse might need to give up their job, and you might have to take your kids out of school and take on, a big expense. You might be moving away from family and friends and things like that. So restricted covenants, some of them are very loose. It's not a big deal. It's just a really short geographic area. It's a short amount of time, or if you violate it, the penalty is very mild, but it can be pretty significant. So just really be aware of any restricted covenant in your contract. If restricted covenant is going to create a real hardship for you, then you're going to want to ask to have it removed from your contract or modified some. And if they're not willing to remove or modify it, and it's going to really impact you if things didn't work out, then you should really think twice about signing that contract. And maybe a different job might even make more sense. But the reason why these restricted covenants are in there is essentially to make you a pawn in negotiations, often in between groups. That if there's a change in control, that the whole workforce can go away without a big payout type of thing. And that makes it easier to keep the status quo intact. And of course, that's not going to be good for you to be used in that way, and your partners and colleagues and things like that. It's also not good for the emergency department. You've got a group of docs who kind of know how things work and are working well as a team. Replacing them isn't going to really be a good thing. So beware of restrictive covenants. You can learn a lot more about them on the AAEM white paper on restrictive covenant. Restrictive covenants are illegal in a variety of different states and unenforceable in those states. It can be contested if it is in your contract. Like in California, AAEM litigated with a contract group on the Mount Diablo case when they had what we felt a legal restrictive covenant in place, and AAEM pushed the issue pretty hard and litigated, and eventually they backed down and settled, and etc. In Tennessee, where I am with Tennessee AAEM, we were able to get legislation that exempts emergency physicians from restrictive covenants, which of course protects us in that state. And then there's kind of modifications on this, more of a poison pill type of thing that are sometimes used by Democratic groups. And if it's implemented appropriately, then it doesn't really restrict you, but it can give a little bit of protection to your group. So much of it is in kind of how does this language look. Now, there is a different type of thing, non-interference clauses, which are going to be pretty standard in most contracts. Non-interference clauses are pretty much saying that you can't go behind your employer's back to try to steal the contract, and you can't hire away nurses and techs and other doctors, for a competing entity or things like that. And I do think that, non-interference clauses are legit, those are ethical. It's not something you really should be doing. But you have to be careful if you've got a clause like that in place, and maybe the employer is being abusive, and you are thinking about doing some sort of end run around them. Then just understand what's in your contract, that you can be open to violating a non-interference clause, potentially liable for tortious interference or other things like that. Bob, you'll need to unmute yourself.
Yep, med mal issues. The most pleasant topic. We had that presentation earlier from the guy who was septic and lost all his limbs. So this is this is going to be a key part of your contract. So you've got to look at this very carefully. So the amount of coverage, you see these things like 1 million, 3 million, 2 million, 6 million. That's per event is what you're looking at there. So if you have, if you got sued 3 times in a year and they were all 1 million, you would run up to your limits both for those and for the total year. So hopefully you won't have multiple per year. This is generally set by the state. Like Pennsylvania, for instance, requires physicians to have a $1 million, $3 million policy. If you're going to get your license, you got to attest to the fact that you are adequately covered with med mal insurance. Now, on occasion, hospital will actually want more. If they're in an area that's highly litigious, they'll be, if you think about an emergency physician, having an issue, the lawyers will sue the hospital as well, saying that you're an agent of the hospital. Hey, you hired this doctor to work in the emergency department. My patient went to hospital X, not to Dr. Y. Therefore, you're going to be the one that's going to be responsible for backing up anything above their $1 million policy. So we've seen this happen. 2 million, 6 million is actually pretty common. We know this happened all over the state of California, but usually set by the state. There's always these rumors that, I probably want more because I don't want to have my personal assets at risk. That is a rare thing. To have a doctor actually their personal assets attacked above their insurance limits. I've asked for examples of it from, we have a big health system here. They have none. They have none in this entire state of Pennsylvania, because there's always this, threat put out there that, they could come after you, your family. So if you have more, if you have a $2 million policy versus 1 million, then you're a bigger target, right? So, we can get more, and quote unquote, the doctor won't be paying. So there's a mixed bag depending on how much coverage you have. In general, I think the basic thing I tell people is, look, whatever the state requirement is, that's what you want to get. You really got to do something beyond the pale have any threat of your personal assets being attacked. And hopefully most emergency physicians are not going to find themselves in that trap. All right, so I don't know the level of skill of the audience, but certainly occurrence versus claims made is it's a big issue. The occurrence means that anything that occurs while you are insured, we're going to cover that. Claims made is any claim that's made while you're insured will cover that. So theoretically, if your insurance ends on June 30th and you had a patient bad outcome on June 29th, you may not be covered July 1st when that lawsuit comes around 2 years later. So occurrence, basically anything that happened while you're working there, you're covered even if you leave the place. Claims made, you've got to have what's called a tail coverage, where you've got to buy enough insurance to make it into an occurrence type policy. That can be very expensive, depending on what market you're in, how long you were there, what your level of exposure was. So if you get offered a claims made policy, you need to find out who's going to be paying the tail. Is that going to be me? And if that's going to be on you, you got to throw tens of thousands of dollars into your calculation of what it's going to cost you when you leave this group. We've also seen things where groups bind you to them by saying that if you don't give us a year's notice, you're going to have to pay the tail. That's another punitive contract thing we've seen. I think that's pretty obscene to make you give a year's notice. I mean, who knows what can happen in the course of a year. The other thing with MedMal is, who's going to have the power to settle the case? What is going to be your input into the case? If it's the big business, if the Envision, the Team Health, the large health system is providing you with your MedMal insurance, you got to know, like, all right, well, what's my say? If I have a case against me, do you listen to the doctors? You get my input? I think the right to refuse to settle is, that's one of those things that's kind of fading away. I think, the golden rule, who has the gold rules applies in a lot of circumstances, that, a power bigger than you would probably be able to settle if they really saw the case is indefensible. And at that point, they would try to convince you, the wisdom of settling and trying to fight it. But that's, again, another thing. Who makes the decision about settling these MedMal cases? I can tell you, if you're working for one of the large corporate groups, it's probably not going to be somebody who even knows you. It's not going to be your director. It's going to be somebody above your director. Maybe your regional director will have input, or maybe it'll just be, one or two docs at the national level who say, all right, let's look at this case, maybe talk to the local director. What kind of witness do you think McNamara will be? What's your community like? So, this is a key issue. This is, one of the reasons why we advocate physician-owned groups, because, if you own it, if you own the group and you're buying this, the more chance you're going to have some input into the MedMal settlement or not.
All right, when you're looking at your contract, certainly you want to have a really good understanding of what does the compensation look like, any sort of bonuses or incentives or hour minimums and maximums, okay? So everything should be very transparent. It should be really clear cut what you're going to get, okay? Pay should certainly be, a fair market value for, services rendered for that. You really want to not be taken advantage of. Unfortunately, there's a lot of profit seekers in emergency medicine that will try to take 20 to 50+% of the emergency physician professional fee above and beyond fair market value in terms of all costs already in there. RVU formulas are becoming increasingly common, where you're essentially incentivized on productivity, either as a separate incentive or sometimes straight productivity, where 100% of your salary is based on the RVUs, relative value units that you generate. Again, it should be pretty clear cut how this formula works and what you're going to get out of it. It should be very reasonable. In general, if you were to switch somebody from a salary model to a RVU 100% productivity model, typically that's going to improve productivity by 20–30%. You shouldn't be getting the same compensation being 100% at risk on productivity as you would if you were not at risk, because again, you're going to be more productive and you're the one who's definitely taking on that risk if something happens, like, there's a big national pandemic that, hits the country in, March or April of 2020, and emergency department volumes drop by 60% for a couple of months. If you're on 100% RVU, then you're the one who's taking the risk for that rather than your employer. Bonuses are becoming increasingly common, and incentives, some of them are very reasonable. Okay, it's a very reasonable carrot. Sometimes there's a real stick to it. If you've got a decent performing emergency department and they're trying to incentivize you for greater than 50th percentile on certain things like productivity or patient satisfaction, or for the group on left out being seen or things like that, that's probably pretty reasonable. If instead it's a average emergency department or below average running emergency department, and in order to reach your incentives, you have to be hitting the 90th percentile, well, that's probably not going to happen, and you shouldn't count on that. And it's really just kind of words on a piece of paper that aren't going to mean anything to you. Sometimes things are written in crazy ways, that they want the group to hit the 90th percentile on 5 different metrics, and it's all or none. Well, statistically, the odds of that happening, even if you're an incredibly performing group at an incredibly performing hospital, is incredibly low. So it's not a fair incentive. Pay differentials might be in place for nights and weekends and holidays. Something to consider. Hours worked, there might be a guaranteed minimum. Minimums are good or bad. A guaranteed minimum means that's great, that if I've got 1,600 hours guaranteed, and something happens, like a national pandemic or something, they can't drop me to 800 hours or 1,000 hours, and I'm going to earn a lot less than I expected. On the other hand, a lot of times, you're also guaranteeing the minimum. You have to work this amount of hours. I reviewed a contract for one of my residents just this morning, and if he works less than his 1,650 hours that is guaranteed to him and he's guaranteeing to them, then he has to reimburse them at the same rate for every hour that he works short of that. So just understand what you're getting into. I don't think there's anything wrong with these types of things, but it should be very clear to you, and you should be very comfortable with what you're agreeing to. Indemnification clauses and penalties, these are becoming much more common in contracts. These are big no-nos, okay? That a lot of times they're going to want you to indemnify the group or indemnify the hospital from anything that you do. So if you're sued for med mal, if you're sued for something else, that you're saying, I'm going to take on all of the risk, and that my employer is not going to take on this risk or other things like that. That's an enormous amount of risk for an individual to take on that can easily personally bankrupt you. So if you have indemnification clauses where you're asked to indemnify somebody, another entity, and they're not indemnifying you, you want to really look at that and make sure you're comfortable with that. That's certainly one that you might want to have an attorney review. But most contracts don't have them, but I'm certainly seeing more and more contracts that are asking you to indemnify others. Early departure penalties, these are pretty common if there's some sort of a sign-on bonus or something like that. Sometimes you can get residents who are taking on a job might get a stipend during residency. There could be loan repayment, but all these types of things, the expectation is if you don't carry out your end, if you don't work for as long as they expect you, then you're going to have some sort of penalty where you're going to have to pay back what they gave you, often with interest or penalty. And that's not an unreasonable thing for that. But again, you should know what you're getting into. If you're going to be taking on a whole bunch of money up front, and then you think you might be jumping ship in a year, that can be quite costly for you to honor your contract properly. Occasionally, they'll even ask you to pay for replacement costs for recruiting another doctor if you're to leave before a certain time period. Again, it's not necessarily inappropriate or unethical, but you really got to know what you're getting into. All right, and that is our presentation, and we're happy to take questions from the group. Maureen, I don't know if you're trying to speak right now, but you're on mute right now.
So is there any way where, we can, determine what's fair market value? Because I'm a PGY2 right now, so, I will be going through the process, next year, but is there a way that we can determine what's fair market value or what we should look for when we're speaking to recruiters or, if we have to, these different employers?
Yeah, it's a bit tricky because there's a real information asymmetry, especially with the big contract groups where they have salary info on what they're paying people in all these different places, but you usually don't have that info. So you can get national trends pretty easily. The two most respected compensation surveys are probably the Daniel Stern survey and the Medscape survey, which both have a lot of people, and that'll give you an idea of the national average, and they'll often break it up into regions too, and sometimes even into states, but more commonly into regions. But then you really want to be comparing apples to apples, okay? So what you want to get, it's not just, what is your pay compared to the national average? It's things like what is the expected patients per hour or RVUs per hour, that you're going to be expected to see. What does that work out into terms of like dollars per patient, okay? And other types of things like that. And the more that you can learn about the local environment and get a better idea of what is the going rate at a variety of other places in the area, you can get a better idea of how fair it seems to you. Now, of course, you're not going to expect to get the same pay at a place that is a critical access hospital that's seeing 5,000 patients a year than you are at a place that's very high volume and has an expectation for you to see 3 patients an hour. Certainly, we see that compensation is much higher for partners within an independent democratic group compared to working as an employee for a contract management group. Sometimes things aren't that clear cut. A lot of times, democratic groups don't want to give away too much salary information until you've already had, until you're further along in the process and all that, because they don't want that information used against them, in terms of contract threats and stuff like that. Bob, did you have anything you wanted to add?
Yeah, well, when you look at the definition of fair market value, it's essentially, it's said that both parties involved in the negotiation possess full knowledge. And as Mark said, well, we don't possess full knowledge because, you don't know what's being billed nor paid in your name. So that's the real difficulty. Now, there are arguments made that, hey, if the salary I'm paying, and this is mostly on the hospital side, is consistent with what other emergency physicians are making in that geographic area, then that's automatically fair market value, even if I'm sucking off some funds. There's arguments to be held around that, but that's what Mark's saying is you want to look at salary surveys for that region. And again, they're only as good as the salary surveys, and a lot of people answering those surveys, they have no idea what actually was collected in their name. That's why this whole, I don't know if you were on the last talk with David Blatt and Marion Mast, and that's why transparency is the linchpin. I mean, that's my editorial, right? At the corporate control, the linchpin is lack of transparency. As long as we don't know what we're generating, we can't argue fair market value. Like, well, wait a second, you made $100,000 off of me as an independent contractor for putting my name on the schedule? That's illegal fee splitting. So again, this is, beyond you. You're going to be looking for a job. I would say, as Mark said, find out what the going rate is in the community that you're looking at. And, that's how you're going to probably have to decide.
Yeah, so I'm a partner in an independent democratic group, and we're going to share all the information. We know exactly how much is collected in every doctor's name, okay? That's crystal clear to me. And I know exactly what our administrative expenses are, both as a group and mine individually. And then what's left is my take-home pay. It's beyond clear cut. I would say that most practices that are running reasonably well are going to have tops 10 to 20% of their revenue is going to go towards all of their administrative costs, including coding and billing reimbursement and med mal and administrative overhead and things like that. It's not a big number, 10 to 20%, and 20% is probably pretty high, for that. The contract groups are going to typically, in addition to all those expenses, siphon off another 20 to 40, 50% plus. Okay. Now, the tricky thing is they're gonna do everything they can to not let you know what is being billed and, more importantly, collected in your name. So it's tough for you to get an idea of what are they siphoning off, how fair is it, because you don't know what it is. Now, there are occasionally, sometimes with a contract group, they will give you this information to some extent, but it's rare. And then for hospital employee jobs, some of them will be pretty transparent about this stuff, and the majority of them won't. But that's another rule of thumb. If you do have access to how much is truly being collected in your name, then you can just minus out pretty reasonable administrative expenses and then say, hey, is what is left over and I'm being paid, is that fair and reasonable?
Yeah, so in the academic setting, I'm a academic chair. You find varying degrees of transparency, but academic institutions are supposed to establish equal pay for equal work, right? So, that's a key issue for you as a young physician. Hey, I'm coming in and I'm banging out clinical hours. Am I getting paid, what it's worth? So at our shop, everybody gets a monthly statement of what is billed and paid in their name. And, given that we're in a poorest section of the poorest big city in America, Philadelphia, nobody covers their salary and benefits with their collections in an academic practice, but at least they see that. But on the other hand, I give them information as, here's all the salaries across the board of all the faculty. The way you get a raise in academics is you get promoted to associate professor and then full professor, because we tie our salaries to the AAEM, American Association of Medical Colleges salary survey. We target trying to get our faculty as close to the 50th percentile as we can per rank. And the way ranks work is assistants make less than associates and so forth. So, it's transparent. It's not the same as in a community hospital where day one, you're seeing those patients. You should be, getting justly compensated for that.
I had a quick question about kind of the approach to finding some of these jobs. Like, it can be very difficult to find available positions without going through recruiters, but obviously recruiters come with their downsides also. Is there a benefit to approaching a department chair directly, or stick to whatever ads are posted?
Yeah, so I think that recruiters only make sense for a pretty small subset of job applicants. If you really have no ability to do the job search appropriately on your own, then use a recruiter. But the recruiters are going to come with a big price tag. Typically about 10% of your first year earnings is going to be the fee. And although you're not writing them the check for that fee, that fee is going to be paid by your new employer. And that is going to make them less likely to want to hire you versus hiring somebody they don't have to pay. Well, it could be like a $30,000 or $40,000 fee. So it is completely appropriate for you to contact, blindly groups that you don't have any relationship with or any interaction with and are not currently advertising. So if you're in a particular geographic area, it's completely fine for you to research the different hospitals and groups in that area and to contact them directly. Sometimes even calling up the emergency department, asking to speak with one of the emergency physicians working and telling them your situation. Hey, I'm looking, at employment in this area. Can I get your email or your medical director's email to, contact to get some more information about this opportunity. Certainly there are lots of different, classified ads in a lot of different ways on different websites and things like that. Tons of groups are going to be hiring that are not going to place an ad. So if you restrict yourself to somebody who's advertising, you're going to be much more limited. The very best jobs are typically all word of mouth through your networks. You want to really utilize your network of resident colleagues, of faculty colleagues, and friends, and things like that. Go to the conferences, go to AAEM, go to other medical conferences, and try to meet people and get involved in different things and committees and stuff like that, where you have the opportunity to interact with emergency physicians in different practice settings throughout the country. A lot of times that's a great way for you to identify opportunities and hear about good things. The EM Docs Facebook group is something that's being utilized more recently, about people who normally might not post an ad, who are a little quicker to kind of throw something out there that our group is hiring. But yeah, you do not need to use a recruiter by any means.
Yeah, I would say, identify a geographic area or areas where you would consider working. And then just basically, you can go to the American Hospital Association's directory for hospitals and pick out that region. And then, run the list. Is this kind of place I would want to work at? What's the volume? Is this something that would suit my professional needs? And then, as Mark says, go ahead and, contact the director. You can often get that information pretty easily. And with this market being tight, we're expecting it to loosen up a little bit, right? Because volumes have gone back up. Probably a lot of people my age are saying, woo, I dodged COVID, but it's not going away. There's going to be retirements. That 10,000 oversupply isn't until 10 years. So, we're expecting a better market this coming year. But in certain circumstances, you might need to get your foot in the door and say, hey, can I moonlight? Are there moonlighting opportunities? Sort of like a locums, like, let's work 1 or 2 shifts. That's sort of one way, if you really, really are stuck in an area, to try out a couple different places. You go in there, you do a bang up job for a couple shifts, you work with somebody, hey, they're great, and they have a full-time opening, that may be the way to go. Like California always had that reputation that, you wanted to work in Southern California, you had to do locums. You had to go in there and, find what shifts you could, and hopefully somebody would like you, and then they would take you on as a full-timer when the job opened up. I think we're seeing more and more of that across the country.
Any additional questions?
All right.
I don't have any other questions. I just wanted to say thank you guys for having this, and I learned a lot with this presentation.
Absolutely, our pleasure.
You're welcome. All righty, we, I guess, go back to the main rooms. I think what we do, or something like that.
Take care, folks.
Yes, yeah.